not Lieutenant Collier. He is out for the next couple days, and so I am just filling in. If I have not met you, I apologize. I'm Major Kusha. I teach currently OBGYN this senior semester, and today we are just going to be doing our breast exam lecture. And in senior semester, you're going to have the opportunity to do a clinical breast exam on a professional patient, a standardized patient model. So this is important. And I know it's still a couple months away for everybody, but this is a good introduction, and we will go through this very briefly today. So let's get started here. My personal reference for this in my head is Bates. So I stick to that as closely as possible, right? That's our standard. So I would suggest you go to Bates for any info you need. I know that Stanford Medicine also puts out some good videos, but Bates is our standard. And I will tell you that Stanford does vary from Bates a little bit. So for the test purposes, remember Bates, Bates, Bates. All right. Objectives, excellent. You've all got them in the syllabus. All right, so one of the key issues with some of these more personal exams is having to communicate with a patient. So building trust with this patient and having a good exam and presenting that information to your patient is super important, right? It's not just the information that's important, but it's the manner in which we convey that. That influences our patient's decision-making and their own ability to take care of themselves. So we really have to be careful about word choice, I would say, for this particular exam and for pelvic exams too. You're not gonna wanna say unremarkable or unimpressive. We're doing an exam for cancers or growths or lumps, right? We don't wanna say words that have some kind of uncomfortable connotations for some people. You're going to say normal or without abnormality, or you don't have to say anything at all and you can just document appropriately. But you have to be just that much more cognizant of your word choice when you're dealing with some of these exams. And because we're talking, like, the scary thing here is cancer, right? We have a higher index of reaching out to others and seeking consults for these things. So, all right. Easy stuff today, anatomy review, and then we'll go through the evidence surrounding self-breast exams and the preventive recommendations. We'll go through some of a brief overview of the clinical breast exam and then talk about some specific things. And then if you guys have any questions or whatever, chat them in the window and I'll ask questions too. So feel free to, I know I haven't taught you guys before, but feel free to chat up in that chat window. So this is the area of concern for our breast exam. Essentially, we're talking about from the clavicle to the inframammary ridge and then mid-sternum to the mid-axillary line. So we're drawing this, let me put the little drawing tool on it. So we're talking about, you know, as high as the second rib, mid-axillary line, down to the sixth rib about inframammary ridge, and then sternum. So you're actually doing your breast exam on what may not appear like breast tissue. Does anybody have any idea why we extend our breast exam in these other directions? Anybody have any idea why we do that? Yeah, exactly. Jerry Scott's got it. Kirsten has it. Lymph nodes, absolutely correct, because the breast actually drains into all those like 4 lymph node chains that are in the axilla, as well as clavicular lymph node chains and the neck as well. But essentially, right, this is the site where bad stuff can start to appear. And so we are gathering tissue or gathering assessment through all these areas. And don't forget, the breast itself has a tail of Spence, which goes up towards the axilla as well. So the breast tissue is actually making that teardrop too. But you guys have got it. Awesome. All right, so just like everything else that we've learned in IPAP, right, we got to split things into quadrants or zones. And with the breast, that's super important in terms of documentation. So we have a breast here, upper, outer, upper inner, lower outer. Let's say that I find something abnormal in my exam here. Do I just want to write in my note, like, breast mass? I found a breast mass. Now I'm done with the patient, right? Like, how helpful is that to the radiologist or to the next person that I'm writing about? It's not. So the whole point of these quadrants, et cetera, is to help us document, and because breast cancers occur in these quadrants with different incidents. So this upper outer, if I'm remembering this correctly, is where these are most commonly found. But when you're documenting anything, you might want to say 2 centimeter diameter cystic mass, upper outer quadrant, 4 centimeters from nipple, and that's another documentation too. And Kirsten's right, you can also document like a clock. And I think that's on, oh wait, nope, it's right here on this slide. You can also document like a clock, which is extremely helpful. So you just 1 o'clock, 2 o'clock, whatever, and then centimeters from nipple. Documentation is key. So the anatomy within the breast is varied. We've got glandular tissue, fibrous tissue, and fat. And this changes with age, the composition of these things. What other conditions might cause breast tissue to change or to feel different or kind of abnormal? Yes, Robert Schmidt says pregnancy, and I agree, absolutely. Menses, yeah, fluctuating throughout the menstrual cycle, very good. I would also say lactation would change how it feels. And then also cancers, and also things like breast augmentation might change depending on what sort of procedure they had. And in fact, one of our professional patients last semester did have breast augmentation, and it was definitely notable on exam. So that is something that you do not want to confuse you. Anyway, back to anatomy of breast tissue. It's got lobes and lobules, which drain into milk ducts, and they drain essentially into these areas at the nipple itself. So all of these ducts come together and they drain into sinuses at the nipple, and it hangs out there until it's expressed. What other types of discharge might be expressed from the nipple? Not milk for baby, not lactation, but what other things might? Oh, yes. Robert Schmidt says blood. Very, very keen answer. Very good. Okay, pus and from like a mastitis. Sure, that could be a lot of different places. Yeah, absolutely. Or you could have like serous fluid or a whole bunch of things. So remember, this is part of our exam too, right? The nipple. So we need to check for what's coming out of there too. And we'll get into that in a little bit. So the areola is the pigmented part around the nipple. It's got sebaceous glands, smooth muscle. And last time I checked, I think up to like 5 large hairs, 5 notable hairs is totally normal, 5 to 7, I think. Certainly if this person has evidence of excess virilization and lots of hair, and this is a woman, that's a concern, but a couple stray hairs here and there is not abnormal. And breasts being asymmetric as compared to themselves, right? Totally normal in terms of the areola as well. So one areola may look different from the other. 3 millimeters is still considered within normal. And typically in the second trimester, the areola enlarges and darkens. But during pregnancy, there's a lot of changes in the breast itself. in terms of like tenderness and size, and then even like veins and other things that you see going on. All right. So the nipple is essentially, right, this is how baby gets milk, and it's got lots of ducts. And that's really, it's a feeding mechanism, right? There's no hair there. Hair on the nipple itself would be abnormal, but it is a muscular system. It's a muscular system for the expression of milk. And that being said, what is a supernumerary breast? Supernumerary breast. Has anybody heard that or seen that in reading or on a patient or on themselves? Oh, extra nipples, multiple breasts. Good, you guys are thinking. It's not just an extra nipple, but it's very similar. It does have an extra nipple in many occasions, and it's an accessory breast. So, along the milk line, everybody forever is going to remember that phrase, along the milk line, right? So, this is the milk line, is what it's called, right? Like animals who have teats, right? They have a milk line with all these extra nipples. You can have supernumerary nipples themselves, or you can actually have the breast. And this person, and I've seen this on a patient who had just had a baby, and because she was then lactating, yes, she developed her supernumerary breast became evident. For her entire life, she had no idea until she had her baby. And then it essentially appeared in this manner as along the milk line, right? So here's that continued milk line up in the axilla, along the line. And Jeffrey King says it's a sign of good luck in some cultures. Well, that's good. That's good. Then she's got fantastic luck. But definitely document this. And also inform your patient if you find this and they don't know. All right. You guys all said this earlier, too, about lymphatic drainage. They go to the axilla into the anterior and central axillary nodes. And the arm kind of goes to the lateral nodes. The areola itself goes to central axillary nodes, and then can go all the way also to supraclavicular nodes. And when you're doing your exams, right, you're always like, why am I going supraclavicular looking for lymphadenopathy? This is exactly why. All right. How do you differentiate between that and excess fat? Oh, good question. So it would feel like a breast tissue. And in a person who doesn't realize they have it, it would probably only appear, like in my patient, when she was lactating. So it was kind of like it showed up at the same time, so that she was concerned because it seemed to be related to milk production, and that's what the breast was doing. It was producing milk. So it definitely would feel different, and then it might only appear when she's lactating. It may or may not be present. And it would probably have a nipple on it that is different from like a skin tag or anything like that. Okay, so have you guys had peds yet? I can't remember. Is peds? Maybe not. You never get, okay. Okay, so in peds, we talk about puberty and the way that we stage puberty. And this is how you determine if someone's developing on a normal timeline. And essentially that first stage is called thelarchy. It's the physical evidence that puberty is occurring in girls. It's thelarchy. And Tanner stage 2 is when it's considered to be the initiating stage. So that breast bud is Tanner stage 2, right? So this is pre-pubertal, pre-adolescent, everything's kind of flat, same shape. This is thelarchy is occurring. It's Tanner stage 2. You develop a breast bud, and then the areola begins to elevate and develop like a mound of tissue, and eventually becoming the adult shape. But these are indications of puberty, right? It's actually an indication of how well the ovaries are functioning, since they're both estrogen sensitive. So that's why we look at these as indicators of overall pubertal development. So clinical breast exams. The evidence is mixed on clinical breast exams, as it is on self-breast exams. Examiner technique and experience impacts how good it is. It's poorly standardized right now in terms of how it's done. And people are advised to take 5 to 10 minutes for the breast examination. And it's also impacted in premenopausal women by where they are in their menstrual cycle. So for that reason, clinical breast exam, its utility varies significantly. And you guys picked up on this, right? Because breast tissue it fluctuates in texture and other things that are present, right, under the influence of hormones from estrogen. So it feels different. So if you were doing a breast exam on a patient who had a concern for a lump or something or cancer, if you did that exam 2 or 3 days before her menses began, what do you think the problem would be? And I'll just tell you, that's the time period when there's more hormonal influence impacting the breast. So yeah, it's more dense. Yeah, or it's there's changes within it, right? There's hormonal fluctuations, so you can kind of have like these feelings of like cystic nodules or tenderness. So what I'm saying is depending upon when during a menstrual cycle you do this breast exam, it may influence your ability to pick up on any areas of concern. So that's why these are you have to have good technique, and that's why the evidence is still a little bit out on them. All right, so you're gonna provide this to your patients, right? I say things like, "Hi, ma'am, I understand you're here for your well woman exam today. I see that you haven't had a clinical breast exam in several years. I'll offer that to you today. Are you interested in having that done?" And then you ask them about, do you have any concerns about your breasts that you'd like to discuss today, or any areas that are causing you any problems? And something you don't want to do. When you're doing this exam, do you think you want them just to like be completely exposed from the waist up the entire time? You can only examine one breast at a time, right? So yeah, Mr. Charter, Ryan Charter says, don't pretend it's your first time doing it, even if it is, right? And it won't be, because you're going to get practice. That's right. Dana Park says no, right? You want to keep this patient covered. It's a medical procedure, but this is kind of exposing them, right? So you keep them covered. You're going to hope that they came in after their menses, so their breast tissue is a little bit easier to discern, and then you're going to ask them about breast factors. I figured you were kidding. I figured. Yeah, good. Okay, so this is directly from Bates. First you look, right? In all of our physical exam techniques, we look first before we do any touching, right? So in this exam, you definitely need to give your patient a verbal cue, like, I'm going to look at your breast tissue and your skin, so I'm going to have you move your arms in a couple positions. And first, you're just going to say, hey, go ahead, and the patient's sitting, right? So go ahead and put your hands on your lap. And then you're going to ask them to put their hands overhead. Then it's going to be hands on the hips, and they're going to press down to contract their pec. So they're pressing down while they're doing this. And then you're going to kind of have them leaving their hands on their knees. They're just going to lean forward in this last picture, leaning forward in the last picture. So why are we doing these ridiculous exercises? Like, why am I asking this poor patient who's probably freezing cold? Why am I asking her to move around? Kirsten says for checking asymmetry. I like that. Size and asymmetry. I'm also looking for changes in the skin. What about, I'm circling these on the sides. Oh man, I just raced right over that. I'm also looking for what? What might change with movement and positioning? Yeah, contours, chest wall adhesions, right. So by moving her arms, she's moving the underlying musculature and soft tissue, and maybe something abnormal that you won't see in this picture is going to be more evident if she leans forward, right? Or if her breast tissue it dimples or it's flattened as she moves, that's a concern too. It's something underneath is not good. Also, look at the nipples and the shapes, right? You're also looking vaguely for symmetry, not perfect symmetry, right? Vaguely for symmetry. And Tanner staging if it's an adolescent. Yes, and Jesus says peau d'orange, and we will talk about that in a couple slides. Absolutely. You see peau d'orange, that is a concern. Very good. And that's related to some of that dimpling or changes in the skin changes that we're talking about. So very good. You got to do all these maneuvers here with your patient. And now it's time to do some palpation. So this is the area of concern. It's actually, well, remember their arm is moved up, so clavicle has now taken up this oblique position a little bit, but you're doing this whole area for your breast exam. You're going to be on the patient's the same side you're not going to reach over unless there's absolutely no room, but 100% of the time you're going to go to this other side to do the other side. You're not going to reach in front of them. So you're going to go through this whole zone and you're going to do it methodically. And you're going to use what I call the rule of 3. It should be about 3 minutes, 3 fingers, 3 depths of palpation. And you can use a variety of techniques to kind of walk your way over the breast tissue and in the zone. Based upon my minimal knowledge of the comparisons in these different techniques, the best one, the most sensitive is to do this one called the lawnmower, where you're going up and down like that. Some people do wedges or circular. I like this because for documentation purposes, it's easier and you don't really lose your place. You don't really lose your place. Like if you do the circles, I feel like you might just lose your place a little bit easier, but I'm simple. I keep it simple. Other techniques to remember, once you put your hands on your patient, don't take your hands on and off and on and off and on and off. That's very distracting to the patient and it feels very jarring. And you want to alternate between looking at what you're doing and then looking and talking to the patient, right? You want to see for things, but you don't have to stare intently at the tissue. You can also kind of like talk to her as well, just to assuage her concerns. All right, that's easy stuff. We'll get into a little bit more detail. Yes, the lawnmower, the vertical strip pattern, that is the one that I use. It is the only one I have ever used. The literature vaguely shows that it's potentially more sensitive, but I don't know. There's not a right or wrong. So you're going to start outside and laterally, this back and forth. If you find something, you're going to remember it. You're going to ask a question, right? Ma'am, I noticed that you have this scar underneath your breast. It feels kind of, there's a line associated with it and it feels tough. Do you by chance have a history of breast augmentation, or have you had a surgery there, or blah, blah, blah. So like, yeah, you're noting these things and you're talking to your patient about them so that you can ask questions, because your patient, and they say this, your patient knows her breast tissue better than you do. So make sure you're asking her about these things, about any questions you have. When you get to the nipple, you're going to stop and you're not going to pinch the nipple. Bates says you can pinch the nipple. I don't recommend pinching a nipple. That seems a little out of line for a clinical exam. I think it's more professional to use 2 different hands and to drag along the areola radially, because you are trying to express anything from the nipple, if it's there, you're looking for blood, you're looking for galactorrhea, you're looking for serum fluid, okay? So you stop in the middle, you test the areola and nipple, you attempt to incur discharge, nothing happens, you keep going along. Now, your technique, 3 fingers, a terrible picture, I'm not an artist, and you're gonna use 3 levels of pressure, superficial, medium, and then a heavier level of pressure. Not so much that you hurt her, but with good level of pressure that you can ascertain any abnormalities that might be there. All right, couple techniques, lymph nodes. Okay, the most shocking thing that Bates says to me is that you can wear gloves if needed. Wear gloves. I'm going to tell you to wear gloves. If you're assessing someone's lymph nodes and you're digging in their axilla for their comfort and your comfort, please wear gloves. I don't think you're going to have any better chance of finding lymphadenopathy without gloves. Just wear the dang gloves, right? I typically do these on the patient when they're lying down. It's easy for it to flow from the breast exam into the lymph node exam. You're lying down, you're holding their arm for them, and then you're palpating all 4 chains, anterior, posterior, central, axillary, or lateral axillary, and then you're going for the supraclavicular. So Brad DeLong has a good question. What kind of pressure? So it's not the 3 levels of pressure because we're targeting lymph nodes. So you are just going in with a bit more force depending upon their habitus to where you can ascertain those lymph nodes. And remember, in the axilla, you've got some are pretty deep, and your posterior are along the anterior surface of the subscap. So you've got to go pretty deep to find them. So you have to be a little bit intentional with what you're doing. And it's instead of feeling with 3 levels of pressure, kind of in like a pressing and a rubbing motion, you are just going in for the lymph node itself pretty directly. Wear gloves. Wear gloves. Please wear gloves. All right, clinical breast exam techniques. This is what we're looking for. Tenderness, nodules in the breast, and the consistency of the breast tissue. We're going to document it. Kirsten was right. We're going to do quadrants, or we're going to do clock, or we're going to do, we're going to do what's called centimeters from nipple, abbreviated as FN sometimes. Not sure if that's standard, but I see it all the time. So if you see that, from nipple, not from areola, from nipple, that's your landmark. Document the shape, document asymmetry. But remember, what are we not going to say to our patient? We're not going to be like, looks great, ma'am, your breasts look great. Does anybody find that statement problematic? Because that's a little problematic. Not to say things like that to your patient. I got some people type in. Let's see if they think it's a problem too. I hope so. Krista Kelly says, yes, never say that. Just a little somewhat creepy, right? Yes, and I say that because people get nervous, like students get nervous doing your breast exam, right? And you could easily be like, okay, ma'am, looks good. Everything looks fine. Like, as a student, no big deal, but better to practice more, a little bit firmer verbiage explaining what you're actually seeing, right? Nothing looks abnormal, ma'am. Ma'am, I didn't find anything that concerns me. That works. Yeah. All right. All of these things. You're surveying the area, right? You're seeing what goes on. Tenderness, mobility, any masses or lesions that you find. So in terms of concerns for cancer, is it those big, puffy, ropey cysts that concern us? Is it? No, Kirsten says no. I agree. We're taught, right? It's the irregular, the stellate, the hard, painless nodules that are fixed that are concerned. I'll tell you what, though, on a breast exam, it's not that easy to tell the difference. It gets easier, but it's not super easy, right? We can't see what's going on, but certainly things that have these concerning features are very concerning. Special situations. Okay. This is the nipple discharge. There's spontaneous nipple discharge, and then there's provoked nipple discharge. This is my issue with Bates. I don't think female patients would like that. I don't think that seems like super comfortable, right? That could be a lot of force. So it's easier just to use two hands. One hand kind of holds steady, and the other pushes along the nipple, kind of like dragging towards the nipple from a couple directions. So one finger, your index finger, one anchors, and then the other just kind of drags in. But nipple discharge, you're right, is a concern for what? You told me earlier, galactorrhea. Yeah, call the force. No, we're not calling any fours. We're never going to need to call the fours. This is a concern though, right? Because of milky discharge, could just be normal. But if it's bloody, that could be a concern, especially if it's from one or just one duct. There's things that grow in ducts that we don't like, and they're cancers. Yeah, mastitis or cancers, right? Some things are normal, right? You take, like if you have thyroidism or if you have a prolactin, it's potentially you're going to have some expression of lactation, galactorrhea, right? That might be totally normal. Or if you had a baby recently, you could be lactating, right? Totally normal. But if it's got evidence of being bloody or it looks like serous fluid or that would be abnormal. It's ones that are green, black, bloody, and multiductal that only require reassurance. So one duct means maybe something is in that duct that's causing the problem. Multiductal, a little bit less concerning, because it's maybe like a systemic problem or something else. All right. Okay, special situations. I kind of hinted at this with the mastectomy and the augmentation. It could be just like surgically. Oh, question first. How would black or green be benign? What would cause that? So black is probably, I don't know that I've ever seen black. I would say like probably green would be more an indication of an infective process versus a cancerous or a malignant process. You would want to think more of like a mastitis if it's in a couple different ducts, right? You've got a regional little infection versus something is growing in a duct. Yeah. It would be concerning, but not concerning so much for cancer. And yeah, you would still take a sample and send it, but you wouldn't be quite as concerned for cancer. That being said, you would still order follow-on things, right? You might still want to do some tests. Absolutely. Yeah. By concerning, we mean like for malignancy in this case. So mastectomy or augmentation changes your exam, right? It's going to probably change what you see and all kinds of things. A good PA has asked about this prior to them even showing up and prior to them even having their exam, right? You've talked about it when you've reviewed their surgical history. If you can see a scar, take a look for it. And then, right, you still are going to examine the breast tissue as though it was normal breast tissue. You're still going to do the same exam, noting the exact same things. Okay, look, these people still need breast exams, right? These individuals have had mastectomies. This is how it's going to look. It looks a little surprising, especially if they, you haven't seen it before, or if they wear like a clothing that has padding, right? So this can be a surprise. Don't let it surprise you. Just exam like normal. So yes, in pregnancy, here we go. Late pregnancy, areola is bigger and darker. The tissue has gotten larger. Things have grown. And it's possible to have some colostrum discharge throughout pregnancy. So that would not be surprising finding if you're doing the clinical breast exam. Females with double mastectomy still need breast exams. Yes, technically, yes. All right. Breastfeeding can make it uncomfortable. That goes without saying. So if your patient is lactating, they might want to have fed the baby or express milk beforehand. Aging. These are trickier breast exams because the tissue is not where you can easily examine it, right? This person is laying down. If this person is laying down, where is this breast tissue going? Is it staying like on the chest where it's easy to examine? It's going to the side, right? This woman has pendulous breast tissue, right? It's axillary. So you have to adapt your examination to accommodate that. But you still need to gather all the tissue within your exam. So the tissue itself has atrophied, right? This breast is less dense, it's fattier, it's going to feel different. The nipple could be smaller and flatter, and the inframammary ridge under here is sometimes more prominent. Oh goodness, so many problems in clinical breast exams, right? Cyclic swelling with menstrual cycles, tenderness, right? There's so many things to use. Figuring out, like, when do you do a clinical breast exam? When do you order a mammogram, an ultrasound, a biopsy? Does anybody know do we still advise self breast exams for patients? Is that still a thing that we do? Oh, I've got a yes, and then I see mixed things. Yeah, I agree. It's actually, it depends on which consensus body of evidence and which agency you look to. I tell my patients things like the evidence on examining your breasts varies depending upon the subject matter experts. However, I encourage you to continue performing self-breast exams because you are familiar with your breast tissue than I am every few years. It's been shown, I mean, some people have had breast cancer that they've identified from breast masses. So that is why I say that, even though the bodies of evidence are kind of mixed on it. Yeah, exactly. These patients are the best historian and they can tell you what's different, right? So we'll go over that too. So I would still ask your patient these questions about these things, right? Do you examine your breast? Do you have any concerns? Has anything changed? Et cetera, et cetera. This is bad. This is that retraction, dimpling, abnormal contour. This is why we have the patient go through those series of maneuvers, seated and with various arm postures, right? This should concern you for an underlying problem. This is way too late. This person should have come in a long time ago. Oh my goodness. This should not be at their annual well woman. Like, no, ma'am. All right. Common breast masses. These are not that complicated. These are pretty easy. There's 3 of them that we see commonly. Fibroadenomas are typically benign. They are in our younger reproductive women. There's usually like a couple of them. They're kind of round. And they move around a little bit, typically non-tender. That's this guy here. That's your younger, 15 to 25. Your cysts can be a little bit more painful. Those are also benign. And those are more fluid filled technically, but typically all the way through perimenopause, you'll see those, but they're kind of similar. Our fibrocystic changes, these are the ones that fluctuate throughout the menstrual cycle. Fibrocystic changes. They feel kind of, I think the words are like ropey or cobblestone or bumpy. And they can be bilateral, they can be unilateral, right? So this is, honestly, most women have this. and it's kind of this periodic breast pain. They'll let you know. All right, this is someone earlier upstream had said peau d'orange. Does this look like an orange skin, orange peel to anybody? Me, I agree. It does look like an orange. Okay, maybe not the areola, but maybe that's like the stem and the leaf. I don't know. The skin with those little dimpling in it, to me, looks like an orange. This is a concern. This happens because of the lymphatic blockade. It's thick. It's thick. It's very thick, like the rind of an orange almost. It feels thick. And it's often, right, lymphatic blockade. So it often starts on this distal aspect of the breast. So like under or towards the areola is where you'll see it. If you see this, this is like, catch this, or it's the fours, or it's the fours. So yeah, be on the lookout for that. I've never seen it in person. This is literally like on every board question forever is peau d'orange. Mastitis. If you have a baby that is breastfeeding and you have mastitis, should you stop breastfeeding? I know this, but everybody seems to know the answer. Everybody's got it right. Everybody in the chat, you are correct. You do not stop breastfeeding. You take some antibiotics, typically like dicloxacillin. Typically, this is associated with a puerperium. You just had a baby, you're breastfeeding, right? And the bacteria from the baby has given you an infection in the breast. Not great. That probably hurts a whole bunch. But you're going to give them some antibiotics. You're going to tell them if it doesn't get better in a couple days that they need to come back, and they can do like some conservative measures, right? Like take Tylenol for the pain, etc. But you got to keep breastfeeding. This is hot to the touch. You can probably put like maybe like a warm compress on it, maybe cold. I'm not sure. Typically, they tend to get better real quick within like 24 or 48 hours of taking their antibiotics. Tends to consolidate nicely, and it tends to leave. But yeah, baby's got to eat. Does peau d'orange always have dimpling like the picture? Peau d'orange itself refers to that presentation. So yeah, that's like the description of what you see. It's this way to phrase edema of the skin in this very particular way. So yeah, that peau d'orange, if you use the phrase peau d'orange, it's because you saw that. And that's a big clue to people that you work with that you've got to do some investigation. All right. The male breast. Do men get breast cancer? Does anybody think men get breast cancer? Yes, men get breast cancer. They sure do. Not very often, but they do. I've never done a breast exam on a man that didn't come in with a breast concern. It's not a routine screening. Same kind of thing, right? You're looking for all of these issues, but typically it's these guys coming in with concerns about too much tissue. Something they feel like they're developing a breast, like, got something going on, right? Fat can cause that. That is not gynecomastia. The buildup of fat is fat in the breast. The buildup of glandular breast tissue is gynecomastia, and that can also cause some tenderness. And this is a different issue. Different issue. You can palpate the difference, and it looks a little bit different too. Archer had it, like, like from the show. I cannot endorse a commercial product, but I didn't know that. Study that for science. That's homework now. All right. So your patients are going to ask you about breast cancer continuously. So you need to know a little bit about it. We're going to cover it in OBGYN if I'm teaching it next semester. So not to worry. Breast cancer is a concern, though. It's the most common cause of cancer in a woman. So Oh, getting some questions here. Good. How do a male breast examination? Same way. Up and down. Lawnmower. Back and forth. Same thing. Lymph nodes, etc. Oh yeah, HCG. Isn't it normal for boys in puberty to develop some enlarged breast tissue? Yeah, throughout the pubertal process, the presentation can change, can vary, right? Because hormones are fluctuating and the androgens are fluctuating. But like gynecomastia in an adult male, especially like unilateral, you want to figure out like what meds are they taking, what's going on there exactly. Because these people should have like a normal hormonal level, essentially. Steroids. Hey, I used to work in the prison at Fort Leavenworth. So we saw gynecomastia all the time for people who were doing drugs and steroids, etc. Right. So they would always come in with these complaints of like breast problems because they wanted to have their gynecomastia treated while they were in prison. It was like, or age. Yeah, or age. That's true. Roids or age or medications, right? I think Tagamet was the one that was implicated, but a lot of those psych meds have a gynecomastia. If I remembered them, I would tell you what they were, but maybe you guys remember better than I do. No, it's Tagamet, and there's quite a few of them that can cause gynecomastia. Oh, right. Some young women get breast cancer, most often over age 50. Right. Risk factors. Luckily, there's things that we can do to reduce our risk for breast cancer. So not being obese, right? So breast cancer there's a role of estrogen within breast cancer. And estrogen is also related to obesity. Obesity is an estrogenic state as well. Hormone replacement therapy has estrogen in it as part of it. So that, if you can eliminate that, you can reduce your risk. Don't smoke. Don't drink alcohol. Don't be inactive. Contraception can influence breast cancer too. And in fact, contraception can play a role in other cancer risks. So that's why we take such a good history about our patients when they come in for these like well woman visits. So they're known to cause like a slight increase in the relative risk of breast cancer. Things you can't help: family, mutations, history, right? You can't help that stuff. And there's lots and lots of tools out there, lots and lots of tools. I can't really personally endorse one over the other, but know that they're out there, and a lot of them have like apps, right? We need to offload the cognitive burden of some of this stuff. Don't memorize it if there's an app for it, except on the pants. Unfortunately, you have to memorize things for the pants. All right, this is the screening. Hormone, okay, good question. HRT, sorry, we teach this in OBGYN. HRT, hormone replacement therapy. So for women who are postmenopausal or perimenopausal, who are having those stereotypical symptoms like hot flashes, sweating, just all that kind of stuff, you give them essentially estrogen with progesterone to help alleviate those symptoms, or they make estrogen alone. But it's that estrogen component that impacts breast cancer. Would this possibly increase risk for a male transgender patient transitioning to female? Oh, I mean, estrogen therapy? Would this possibly increase risk for a male transgender patient transitioning to female if they're taking estrogen? Probably not, because they don't have the amount of receptors. They don't have the estrogen receptors in the breast that women do. But they're concerned if you're giving exogenous estrogen, it's going to be the thromboembolism. But Devin Earwood, are you talking about commercials for transitioning from male to female? Oh, that's cool, man. I like that. I would have to look that up. I don't have a definitive answer on the transgender, and I've only ever had 2 transgender patients. And I don't remember if we had even assessed neither one of them had yet decided to take estrogen therapy yet, but I would have to look into that. That's a great question. Okay, this is from the book. This is like, I think, one of our last slides here. So this is how all these bodies of evidence differ. And I know you guys always focus on USPSTF. They recommend against self-exams. But you don't have to like read these off to your patient. She probably just wants to leave the appointment and not read this, but you can say things like, different recommendations differ, but we recommend starting at about 40 that you get an annual mammogram, which is what ACOG says. Cancer Society says others. And then I also tell my patients, I recommend the breast exam every 1 to 3 years if they're under 40. But these other two bodies of evidence say not to bother. It hasn't shown a benefit. And they also, ACOG recommends breast self-awareness, and these guys don't. I think it's a good thing to do just for awareness, and it keeps breast cancer in the news, and it keeps it in your patient's mind. But yeah, the evidence is crazy, right? Like, this is very, very different. Brad DeLong says that seems counterproductive. Do you mean mammogram screening or anything like that? Oh, not recommending the self-exam. Oh, this is not recommending that your patient do their own exam. Yeah, I agree. It does seem kind of crazy. Like, why are we continuing to do mammograms and clinical exams if I'm not even going to educate you about it and what it means? Like, as a patient, right? Like, let's pretend I am the junior class's primary care manager. Dear junior class, I see that you're here for your breast exam today. Do you have any areas of concern, pain, tenderness, or breast changes? If you're unable to answer that question, then our medical appointment has lost a lot of value, right? It seems like a good way for patients to let other things go ignored. I agree. So that's why I encourage breast self-awareness. It doesn't hurt anybody, right? And plenty of women will come in with personal stories about how they know somebody whose breast cancer was identified because they started that chain of care. They're the ones who brought it up. So God forbid somebody finds something and you're like, nah, don't worry about it, right? No, absolutely not. Absolutely not. This concludes our lecture for the day. Thank you so much for your questions and your kind attention. Are there any questions I can attempt to answer before we move on? You are very welcome, juniors. I think I will talk to you guys again next week. Yes, Junior Baker, absolutely correct. I am teaching female pelvic exam next week. And then I think I'll be helping out with the GU lab as well, once we sort out the models, etc. I got a quick question here. If you guys want to peel out, that's cool. I don't want to keep you over. I want you to use your hour to study. Pure diagnostic value, self-breast exam would have low, yes. Right, correct. Robert Schmidt, absolutely correct. So when they make those recommendations, they're balancing a lot of factors. They're balancing cost. They're balancing actual reality. They're not just saying what's the gold standard for everybody. They're saying, like, does it make a difference in the population, right? Those are population level things. So they're like, oh, 3 out of 1 million people only died because we didn't do the exam. They're like, that's nothing. But those 3 people are related to you. That's not nothing to me. So that's where that comes from. It's a comparative effectiveness research and cost analysis research. So I agree. Yeah, absolutely. I wouldn't say not to, right? But you also understand the evidence basis behind that. Thanks, you guys. I'm going to peel out of here. This is recorded so that you can, oh, nope, we got a question. Explain what method you recommend. Okay. I'm not going to, Bates, it's not inappropriate. I just feel weird about pinching something. Like, pinching is not like, That's not nice, right? If you're pinching somebody, they feel like it's painful and your patient can sense that, right? So I use, oh wait, I'm on camera. I would grab my dog, but she's like, no. So I don't want to, I have nothing. Okay, so I use like, I'll hold the nipple steady with my non-dominant hand, which is this hand for me. I just kind of apply some tension and then I drag around towards the nipple radially with my other hand or even the back of my hand. And I'm telling my patient ahead of time, ma'am, I'm going to be pushing on your nipple to look for any discharge because you don't want to shock and surprise them with this maneuver, right? I just feel like pinching seems sort of aggressive. And I know Bates says it's okay, but like if I'm the patient, that's not okay. It's very surprising to somebody. So you just kind of do that motion there. Yay. That was the worst demonstration, but we'll get a chance to do it in the lab. Any more questions? See a little bit of typing. I'll hang out for that. And then feel free to email me. I think Lieutenant Collier is going to be down for the count for a bit while he's recuperating. So you can always reach out. So good question from Khalil Harris about screening recommendations. So for OSCEs and all of that stuff, and for the military public health class, I know they teach the USPSTF stuff. But when you're actually talking to your patient, I would use a little bit of judgment and incorporate a couple of these other different recommendations. So you being knowledgeable about what works best for your patient is part of the art to a lot of this care, a lot of this well-woman care. So technically you would not be wrong if you did any of this, but my understanding is that we ask for USPSTF. So for your OSCE, for example, you could tell your patient, oh, I recommend that you have a mammogram every 2 years starting at age 50 or whatever. Or you could say, you know, other things, but I think that's where we focus. As far as what we're tested on, I'm not sure. I have not seen the test. I would have to ask Lieutenant Collier about that. I'm not exactly sure. So, yeah. I think maybe he wrote this paragraph. So I think understanding this and some of the differences will set you up for success. But only he can truly answer that question for you. Does insurance plan play a role in deciding when to screen, or is it depending upon option and policy? I'm sure reimbursement plays a role. Reimbursement plays a huge role in colon cancer screenings right now because some of it's only covered part way, and so I'm sure this is the same, but insurance plans aren't stupid either, and they adhere to evidence guidelines as well. It's just a matter of what their reimbursement is going to be. Like, yeah, so the reimbursement might vary in terms of like what is your copay for a mammogram under the insurance, but I'm pretty sure that insurance plans follow some of these guidelines when they make those determinations. But in terms of copay, I don't know. In terms of what they cover, I don't know. It probably varies significantly. Yeah, thanks, Trina. I'm sorry I don't have better detail on that. I'm in the DoD healthcare system, TRICARE, but I do have some knowledge of some of this stuff in terms of how this all works. Anybody else have any more questions? All right. Seeing none, I will talk to you guys next week. Y'all have a good one.